and thank you for joining us today, and welcome to the launch of the new National Clinical Care Standard on Low Back Pain. My name is Geraldine Doog, and it's my genuine pleasure to be your host for today's event. We are broadcasting from the lands of the Gadigal people of the Eora Nation, and I would like to start by acknowledging the traditional custodians of the various lands on which we meet today, and pay my respects to elders past, present and emerging. Now, our purpose today is to raise awareness of this new low back pain clinical care standard and to improve how this common and often debilitating condition is managed in Australia, because there's quite an emerging consensus that improvements are distinctly possible. A lot of experts have been involved in the development of this standard, and we've brought several of them together today to discuss some key elements. But before I introduce our panel, here's Joe's story about how low back pain affected his life.
My name is Joe Lawrence. I'm an emergency services worker in WA. I'm 35 years old. My first really bad experience with back pain was lifting this hose over this fence, and I just had this radiating pain shoot down to my foot. I went to a doctor and he referred me for an MRI. And this is where things sort of went kind of a bit downhill for me. I read the report, and unfortunately on that report, I'm seeing words like annular tears, disc bulges, fissures, and I'm sort of going, holy crap. What he said is, it's not a bad back for a 60-year-old. And that really put in my head that, I was aging before my time. It pretty much got me into a pattern of avoidance. So it made me think, okay, I'm fragile, what can I do to last as long as possible? I stopped doing any sports that would aggravate it, because I thought, my priority at that stage was lengthening my career. I was now preloaded with negative messages. I was preloaded to think that pain meant damage. I had this bad MRI, I had a bad back, I was fragile, I was broken, I was wrapped myself sort of in cotton wool, and I was just, waiting for the next injury.
The fundamental goal in developing standards like this one is to improve outcomes for people like Joe. We'll return to his story later to hear how receiving the right messaging and care turned his experience of low back pain and his life, I might add, around. Well, now to introduce, it's my pleasure to introduce Associate Professor Liz Marles, who is a Clinical Director at the Commission on Safety and Quality in Healthcare and the Chair of the Topic Working Group for this project. Hello there, Liz.
Hi, Geraldine.
Why is this low back pain so important for the Commission?
So low back pain is a leading cause of disability worldwide, and that burden is increasing. So we know that in Australia, back pain is the number one cause of lost productivity, early retirement and income poverty. It's actually a really huge problem. It's also a common problem. So around 1 in 6 people in Australia will report back problems. And so we know that this is important to the individual as well as to the community.
Do the doctors themselves and people who are treating people at emergency, for instance, departments, do they feel the pressure of this, do you think?
Oh, absolutely. I mean, you're seeing it's a common presentation. I think in terms of in general practice, it's about our second most common presentation. Because it's common and people are also really distressed at the time that they have it, there's no doubt that clinicians feel a lot of concern about how to treat this appropriately.
So why did the Commission decide on a standard like this? Like, how did they develop it?
So what the Commission has done over a number of years is develop these atlases of healthcare variation. And what they do is they map a particular condition or way in which treatment is delivered by a local government area across Australia. And we can see that there is 11.8 times the variation from one local government area to another in terms of the amount of CT imaging for the lumbar spine. We also know that there's 4.8 times the amount of variation in terms of lumbar spine surgery admissions. And I guess quite concerningly, there's 5% increase in opioid prescribing over a 4-year period.
They're extraordinary figures again.
It's big.
Yeah. I mean, there's a difference, isn't there, between low back pain and chronic low back pain.
Yes.
Is it important to distinguish between the two?
So I think what we're trying to do with this clinical care standard is look at a new episode of low back pain. So, that may be someone who's having low back pain for the first time, as in Joe's first episode, or it may be someone who's having a recurrence of their low back pain, or it may actually be someone who's got chronic low back pain but has an acute flare-up. What we're doing is we're taking this new episode of low back pain as an opportunity to break the cycle.
But that's what the standard is interested in.
That's what the standard is interested in. The standard is interested in a new presentation of low back pain.
Can you take us through the care, in effect, described in the standard?
Yeah, so the standard has 8 quality statements, and you can see that on the screen, the 8 statements. And for each statement, it's an evidence-based statement. It's also had expert input, and it has guidance for clinicians, for the consumer, and also for the healthcare service provider. And in addition, we've put in some quality improvement indicators so that services can actually monitor how well they're managing low back pain according to the standard.
By the sound of it, just looking at the specifics, I suppose, clarity is very important here. Is that what you think has been slightly missing?
So I think it's clarity, and it's having a consistent approach across disciplines and providers. So, just to sort of go through the approach a little bit that we're outlining in the standard, the first thing we want to do is have a proper clinical assessment where you can actually recognise the signs of serious pathology. So even though that's rare, it's only like 1 to 3% of low back pain presentations will have an underlying serious pathology. We still need to have it in the back of our mind when we do that initial assessment. We might be wanting to rule out things like infection, so checking for fever, checking for neurological deficits. It may be something that's not even to do with the spine, like a leaking aortic aneurysm, but you need to be thinking broadly when you do that first assessment to rule out that serious pathology. And obviously, if you find it, then you're going to take an approach with specialist referral and imaging.
I noticed the second one was a psychosocial assessment.
So psychosocial assessment is really important because that's actually, that's treating the individual person in the context of their lives and understanding that psychosocial factors will impact on their interpretation of pain as well. So it's part of our assessment of the low back pain is to consider a psychosocial assessment as well.
And the way the clinician talks to the person is obviously, by the sound of this, critical.
Oh, I think it's really important. We need to understand what that person's concerns are and make sure that we have actually addressed them. We need to set expectations for them of, how they can expect this to proceed. So assuming that we've ruled out underlying serious pathology, we're then going to say, well, I'm expecting this back pain is going to improve quite rapidly without too much intervention at all, probably with no intervention, but I'm going to review you in a short period of time just to make sure that it is actually following that pattern that we expect. But you should be fine to be able to carry on these activities over that time.
So are you really saying, if I hear it, that most people can be given the message that they will improve themselves without big intervention? Why then do we have those sorts of rates that we're seeing?
Well, I think there's no doubt that when someone has an acute episode of low back pain, they are quite distressed and they are in pain and they present to, either the emergency department or they might present to a GP or a physio, but they're in significant distress at that point, and the natural instinct is to want to do something. And wanting to do something might be ordering imaging, or it might be giving them quite a lot of pain relief. And you feel like you're doing something might help them, but in fact it can be quite counterproductive to do those things, to over-investigate, because of what Joe said. It has a big impact on the way in which the person sees themselves. They start to self-moderate their activities, and that can actually make the pain more chronic. It can make it last longer. So it's really important that we have confidence in our own clinical assessment and to know that the most appropriate thing to do once we've ruled out the serious underlying pathology is to provide advice on self-management and to set in place a review.
Even if the patient is appealing to you for more?
Yes, so I think we do need to explain to people why imaging is not necessarily useful, that lots of imaging will show things that may have nothing to do with their current pain. And in fact, we know that a whole lot of people have no pain, can have imaging that will show things. It's the sort of wear and tear of life, if you like, but it can send the wrong message to the person, as we've seen in Joe's case.
It's a sort of a different understanding. It's medicine applied differently in a sense, isn't it?
Yeah, I mean, it can be a little bit counterintuitive. I mean, we think that, we're doing the right thing when we do more things, but in fact, doing more things can actually be harmful.
All right, well, look, thank you very much, Liz, for that introduction to the standard. Now that we understand what good care looks like, we're going to hear the rest of Joe's story, you'll be pleased to hear, and see how the care outlined in the standard made such a difference to him.
So after the 3 years of being in this negative space, getting bombarded with these negative messages, I actually had a re-injury, which for my mental health was absolutely awful, but it meant that I sought a second opinion. He got me to bring my MRI in, and as opposed to the first doctor that said, this is a great back for a 60-year-old, he's just thrown it out and gone, yep, all normal age-related change. And then he just started getting me to move. He just reassured me that any pain I was feeling was normal, and actually that the pathway through it was to gain confidence, was to actually move in a natural way. It gave me my life back. I can't even explain how happy that made me to get back on track. So essentially I brought a list of activities to the physio, like this is what I've stopped doing as a result of my pain, and he just went down the list and went, yep, you can do that, you can do that, you can do that, you can do that, and surely one after the other, he took what was important to me and actually made that the goals of my rehab program. There's just so many people out there that are suffering unnecessarily, and I think that these clinical care standards can really help that.
Well, it's great to see how the right messages and simple strategies can be so transformative. It's a fantastic story, and I think Joe's got a future in television too somehow. Look, we're very privileged to have some leading experts on the management of low back pain here with us today. Professor Michael Nicholas is a clinical psychologist with over 40 years of experience who's published extensively on pain. He's Director of Pain Education at the University of Sydney and Pain Management at the Royal North Shore Hospital. Professor Peter O'Sullivan is an internationally recognised clinician, researcher and educator in physiotherapy. He's a specialist musculoskeletal physiotherapist and Professor of Musculoskeletal Physiotherapy at Curtin University. And Dr. James Edwards works clinically as an emergency physician at Royal Prince Alfred Hospital, and he's director of the department there. He has conducted research on low back pain care in the ED, including the successful SHAPED trial. Now, before we get into the discussion, I really want to thank those of you who described for us your key challenges in managing low back pain when you registered for this event. You'll be pleased to know, I'm sure, that many of those challenges are addressed in the standard, and we'll be covering a number of those issues in our panel discussion today. So, look, thank you all very much indeed for joining us today. Look, I want to ask each of you your response to Joe's remarkable story. Peter.
Look, I think Joe highlights the tragedy of back pain in our society, that often the wrong messages are given, and those messages lead people down a bad path. Joe talked about the story of this idea of a fit, healthy guy in a job that demanded he use his back and have confidence on it. And the imaging left him think he had a back that was fragile and damaged. So that naturally,
he was broken.
Yeah, that naturally led him to think, I need to protect this back. And by protecting it, he started to avoid the very things that we know are important to keep your back healthy. So it kind of sets this perfect trap where the messages lead to over worry, a lack of confidence, over protection, avoidance, and leads you in a path that actually feeds the very thing that you're frightened of.
Yeah.
And I think that's the tragedy we often see around the messaging at the moment around back pain. And then the other story is the story of hope, of where the imaging is explained to him in an honest way to say, look, these are normal findings in a person of your age, and that actually moving and engaging in life is the very thing that will help you build your confidence, get your back healthy, get it strong, and get you back to living again. And that's the story of hope that I think the Standard brings.
And how did you see it, Michael, as a psychologist?
Well, I thought it was a classic of the genre. You saw the focus on technology, that somehow the scan would explain things. And when it didn't, that was the end of the consultation, it seemed. And then Joe was left to sort of think all the sort of things he described. And what the standards indicate is that you've got to go beyond the scan. You've got to ask, what are your concerns, Joe? What are you worried about here? And then address those. And that is often missed because it's busy in ED. I'm sure James can tell us about that. But it's essential for the examination that it's not just about symptoms of something or ruling out something that's potentially very serious, and then organising a scan. It's actually then eliciting from the patient what their concerns are and addressing those. Simply telling somebody they've got the back of a 60-year-old and they'll be fine is not reassurance, because that wasn't what his worry was. So that is the task for training of people doing this work, and the standards, we hope, will provide more impetus to achieve that standard.
What do you think, James? Was that doctor just too busy or what?
Look, I think everyone's lacking time as physicians, and I guess Joe's story really resonated with me as an emergency physician. I see people like Joe come in with their MRI scans, really saying, I've got a bad back, what can you do to fix me? But it also made me reflect on, as an emergency physician, often I do a history and exam, and just to be sure, just to be safe, I give them an MRI form. And I do that, and my junior doctors do that with me, and we think we're being helpful, but I think what this really emphasises, we don't often have that discussion about what could be normal MRI findings for that age group, and then the downstream impact of that is something we don't always think about from the emergency department.
If you had to nominate something you'd like to see shift, given that you are thinking about it now, in your practice of low back pain, what would it be? What do you hope might shift?
Look, I think the real focus is on taking a history and examination. What emergency departments really, their focus is to look at and try and identify serious causes of back pain. And that can be usually done with a really thorough history and exam, and also have that psychosocial assessment, which Michael mentioned. I think once they're done and we really haven't found a serious potential cause of that back pain, then really sitting down, understanding what they've come to the emergency department for, whether it's for reassurance, whether it's to help with their analgesia. Once we know why they're here, we can actually give them a bit of information, and really those key information about keeping active, trying to avoid imaging, because as we know, in the absence of some of those signs for serious disease, imaging is likely not to show anything, or not to show something would be concerning. And also in regard to analgesia, sometimes we can give paracetamol, non-steroidals, and really probably avoid opiates, especially for discharging people on opiates, because we do know that, unfortunately, once you're discharged from emergency department on an opiate, you're often still on that opiates, a couple of months later.
And key shift in your eyes, Michael?
Well, as James indicated, it's not seeing psychosocial as an afterthought. It's actually it should be part of the initial assessment to understand the context from which this patient is coming, and clarifying what the issues seem to be, and then addressing those. And that can't just be done by prescribing another analgesic or increasing the dose, or sending off for more scans. It may feel that you're doing something, as we heard earlier, and the patient may be happy with that because they think something's happening. But the reality is, in the vast majority, over 95% of cases, those things are not indicated. And what is important is to address the person. And that's why we talk about person-centred care. That it's based on the assessment of this person, not based on their back.
And I suppose as a physio, you'd say, would you agree with that, Peter?
Absolutely. Look, you know, from a physiotherapy perspective, of course, we want to screen for serious pathology. You know, it does present to physiotherapists in a very small number of cases, but the majority of our patients are like Joe. They may come with scans, or they may be looking for scans, and they're often worried. They're often anxious. They've talked to people. They've Googled. They've got someone who's had a back problem, who's been out of work. There's this kind of societal anxiety around back pain, which I think is permeated, right through the health system as well. And I think the messaging around the standards is, look, you will get better. Like, you can engage in movement and activity, and it's safe. It may cause some discomfort, but it's safe.
Well, now,
and I think that recovery journey is so important to build the confidence in the patient.
So in terms of discomfort or pain, is this where you really want to see a shift in the way you talk to the patient about
Absolutely,
pain?
yeah, because often we think pain means I'm damaged, and so doing something that hurts means I'm doing more harm. It's a natural thought. Where if those tissues are sensitive, engaging with it is actually not going to harm you as long as you do that in a graduated way. And in fact, we know it speeds recovery. So I think that's the important role of a clinician, to say, look, we know this is painful, but we know that you'll get out of this quicker if we give you a program that is graduated and sensible, and it puts you in control so that you can get back to all those things you value and build your confidence back in your body.
I feel you want to say
Yeah,
something.
I do want to say something. You're right, yes. No, I was just going to pick up on that in terms of talking about the pain, because I think it is a bit of a shift to think that, what we're doing with analgesia is not to try and eliminate pain, but it's actually to try and manage the pain so that someone can engage in all of that functional activity that you've just described. And so we do talk about that in the standard as well. That the role of analgesia is really to help people's functionality, not to eliminate pain.
That's a big change in possibly patient expectations, I'd suggest to you all. Really, when you think about the way the conversation in the public tends to go. So are you going to do that in sort of half an hour? How are you going to do that?
Well, that's right. This does take time, and there's not much time in ED, but you can certainly do a screen for these issues and then identify an appropriate course to take and identify who might be able to assist that, because it's not a one size fits all, and not a one stop fits all. So you may need to bring in a more multidisciplinary approach,
right?
Working with the physiotherapist, like Peter, for example, and others. In some cases, it would be probably good to get a psychologist involved. But it's very important to be linking up with others who can assist, and not have so many doctors sort of painting themselves into a corner, as if they've got to pull rabbits out of a hat with this person. And this is obviously not helpful for the clinician. It's not helpful for the patient. So it's having that discussion about what's the course of action from here.
I can see
that can be done without a lot of time. And if necessary, obviously you can have repeat appointments, but that's easier done in an outpatient or in community care or primary care settings through the GP. So it's using those resources more effectively in a collaborative and coordinated way.
You're nodding your head, James.
Look, I think most of the people with low back pain we see in emergency departments, we see them once, and it's, I guess, episodic care. And I think really most people with back pain are managed in the community by that multidisciplinary team. And I think it's important for us, when people leave the emergency department, we leave them with some hope that there is actually help out there, and people will be looking after them, and it's not we couldn't fix you here, it's not our problem anymore. So I think that's messaging is really important.
Yeah, and can I just sort of say that from the perspective of general practice, because we do have the advantage of having a long-term relationship with our patients, so we do know them, we often use review as a safety net, just in case we have missed something or some new symptom may develop, that we get that person back, we review them, and if there's something that's not going as we would expect, then we may go back and review the diagnosis again. So, it's a way in which we can confidently encourage a person to take on self-management.
To trust, by the sound of it.
Yeah, but, to not feel like, they we've dismissed them, if you like. We are going to keep an eye on this. We're going to keep reviewing it, and we're going to make sure that we get them to the right people to get them better if it's not going the way we expect it to go.
See, what if the person who presents to ED doesn't have a GP? I mean, you're assuming that they will go back to primary care. What if they don't have anybody?
Well, I am a GP, and I would say it's a great opportunity to talk to a person about why it's good to try and find a GP, find a general practitioner, because certainly as you get older, and particularly in terms of managing any kind of chronic conditions, having someone who actually knows you is going to help you not be over-investigated, not be over-pathologised, if you like, in terms of the way in which we view that person, and to have much more tailored care. It also means that we're far less likely to see things fall through the cracks if you actually have a pre-existing relationship with someone. So I do think it's important that we encourage people to try and find a GP if they don't have one.
Yeah, and look, I think coming on from that as well, from our perspective, I think people have a view of a physiotherapist as someone they go in and lie on the couch and get a rub. And I think that's a huge problem. Patients fundamentally want to know what's going on and have a plan to get back to living again. And I think the role of physiotherapy has really shifted to being a critical educator, like to educate people about what's happening, consider their concerns.
What do you mean? What do you mean educate?
Yeah, like to educate them that like this is
about their body.
Like thoroughly examine them and go, there is no sign that there is nerve compression. There's no indication of serious pathology here. You might have sprained your back, and like any sprain, you need to re-engage with movement and activity, and we'll make a plan and we'll make it graduated, and we'll make sure that you're confident with the process to put you in charge. And I think that's the key thing around this, is that self-empowerment around not relying on someone to fix you, but actually to put you in charge of your health so that you build your confidence and get back to living again. And that's a really important shift, I think, within the health system, to think about empowering our patients to be self-carers, and we assist in that journey to support them rather than relying on us to be the fixers, which we know just doesn't work well.
I mean, I'm just thinking again, an ED doctor is particularly busy, but how do you, from your experience and thinking that there's a lot of doctors watching, how do you think doctors will be approached by their patients if they take this view?
Look, I think most doctors agree with, I guess, that self-empowerment. I think we are recognising that, it's not just a pill or an operation that gets people back, especially with acute and going to chronic back pain. So I think it's really trying to, especially those who are working more in the community, such as general practitioners, really supportive of approach.
I mean, Michael, it's almost like a psychological approach, isn't it? There's almost like an overlap there.
Entirely, yes. And this is why it's silly to think in terms of physical or psychological, so they're separate worlds. They overlap, they interact. And you saw in Joe's case, his beliefs following the scan, being told it was that of a 60-year-old, and not followed through with them about, well, what does it actually mean? He was left to think about it, and he thought all these things. And so he started to get into trouble from there. And so that's, I guess, psychologists are used to dealing with that, but there aren't enough psychologists to do this. And a lot of people wouldn't want to go to a psychologist. They say, oh, you're telling me it's all in my head. But in fact, which is, of course, not true, but the key thing is to skill up the physicians, the GPs, and the physios to incorporate more psychological work in their normal work, rather than see themselves as just there to give someone a back rub. You've got to interact with the person. It requires communication skills. You've got to be able to elicit concerns they may have and think about what your skills are for dealing with those. It doesn't mean you have to become a psychologist, but you can use psychology very effectively. And that's what you see in good practices, people doing that. It's just that, unfortunately for Joe, it took 3 years.
Yeah. Well, indeed. And he obviously didn't even recognise himself. He was heading down the sense of being a different man in his own view, and he was 35 or 33.
And that's common.
Is it?
Yes. Yeah, it's really common. We know that there are many people in our community who have given up on care, who are not functioning well, who are disabled. Others are just constantly looking for more care. We've got pain clinics with huge waiting lists. So those people have a beginning. And I think the standard talks about the beginning of the journey to go, let's set the course right. Let's get the messaging right. Let's support this person, not just send them off with a handout, but actually support them, follow them up, make sure that they're tracking down the right path. And if they're not, we need to refer them to get additional support and care so that their concerns are addressed, I think is the main thing.
The other side of it is that the person lives in an environment. So Joe lives in a world. He's got a family, he's got an employer. They are part of his world, and they must be, I think, brought into the story. We can't just take the sort of individual approach and say the problem's all in Joe.
No.
His employer needs to be better skilled in how to manage people. I mean, I've interviewed people in workplaces where they have one policy for people with a workers' comp claim, where they learn all this sort of guideline stuff they'll tend to try to follow. But if you don't have a claim, you're just treated as another back pain loser, a whinger, and they're not interested. When in fact, that is actually disastrous for someone like Joe, because if you're not getting support, and employers can make work a little bit easier, can modify duties if they know about it. And same at home, if the relationship issues, you need to think about these things, because if Joe can't do all these things, who's going to do them? It's the spouse. And if he's on a lot of drugs, then he's going to be out of it. So these have an impact. But our health system is very much focused on the individual with the problem, not on the context in which they live. And our system has trouble with that.
Does the standard offer sentences and phrases that will help people dealing? Because it sounds to me as if this consistent messaging of possibility is critical. Is that in there in the standard?
Yes. I mean, the standard very much talks about how you can conduct these kinds of consultations and about setting expectations with people, and how you can make the person themselves feel confident that they're still being looked after by outlining the process, which will include review and appropriate referral to other practitioners as needed. But in the first instance, self-management is absolutely the way in which we want to go.
Now, I just want to focus a bit on this idea of helping the patient understand that self-care is the way to go. Now, could a patient who's in considerable distress, and I can think of members of my family in this, who the last thing they want to be involved in or asked is to go back to them. They want an expert to take over. That's exactly what they're seeking. Now, how do you help that person sort of, in effect, see other possibilities?
Look, I think the key thing here, we're not abandoning people. And so the self-care idea is not that you go home and it's all on your own. The self-care is about writing out a plan, agreeing to a plan, setting a course, reassessing the course, making sure that the person's tracking right. So that's actually taking the person on a journey.
So it's quite intensive in a way.
Well, it can be, but in a lot of cases, it's just the person knowing it's okay to move. So sometimes that can be a really short intervention. I mean, I had a chap just recently, and I wrote in bold. He's really worried. He's going, I think I need a scan. I said, I wrote in bold, you will get better. And he came back to me a week later. He goes, I'm better. And I go, what was it? He said, you said to me it will get better. That was what it was. Like, it was the words that counted. It wasn't anything you did. I'd said, look, it's okay to keep moving. I want you to keep engaged with this. Don't rest. Don't overprotect your back. It delays recovery. And that comes down to trust, of course, and that the person knows you've taken their problem seriously. You've thoroughly examined them. You've explained things clearly, and you set a clear path. And I think, that's about therapeutic relationship, that the patient can trust you, that you haven't just fobbed them off and ignored their concerns.
Do you have time for this in ED?
Oh, look, I mean, there is definitely some parts. I mean, I think one of the things that's really emphasised to me is the importance of language. Just one-off words that we can say, which we don't think about, but actually can have ongoing impacts. And I think that's really with Joe's story. So I'm really kind of careful about what the language about when people are being discharged from medical department, again, not feeling abandoned, giving some really realistic expectations what will happen. And I guess they do want that reassurance and trust that a senior physician has looked at them, taken a good history and examination. And for most people, that's enough.
Yeah.
They don't need the test.
Yeah.
I think that's what we really want to emphasise.
Do you? You do? Because I thought they might just say, no, I want the test.
Oh, look, there are some more difficult conversations, but generally, it's if you spent the time. I think they can recognise when you're so rushed, you just want to get out of that room. You don't need the test. It's different to you take a seat, you sit down, you listen, and then you say, I've taken a thorough history. I've examined you based on the standard, which is really reassuring that in our experience, you don't require imaging, and that you'd be okay to be followed up in the community. And if something changes within the community, then again, you'll be reassessed.
And that's the point about starting at the beginning, isn't
That's
it?
right.
As opposed to
That's
having
right.
them come in when they're semi-chronic or whatever.
Yes, exactly.
Yeah. And Michael, again, any particular, I just wonder whether you've had any stories that you particularly know of patients who you've seen this work very well with.
One of the things that I think is critical, and we bring this out in the standards, is that importance of that initial assessment. Those first two elements. One is the physiological, the medical assessment, but second is psychosocial. And what I do with patients, even if they've had it for 20 years, is to sit down with a piece of paper and draw out a map of what's happened to them. And I call this a case formulation. And we look at all the things that have happened. And you soon see that their problem isn't just pain. There are many problems and they interact. And often people haven't thought about it like that. They just thought, my problem's in my back, fix my back and I'll be fine. Now, that obviously is true for some, but when it becomes chronic, that's unlikely to be the case. So you've got to actually do that assessment, as we've heard, but then present that in a way that the patient can understand and make sense of. Once you've got that sense, then they will follow Pete's advice, then they will trust you. But if you just say, there's nothing wrong with you, you'll be fine, you've lost that patient. It won't work.
Look, that's a very hopeful conversation. Thank you very much indeed. I've enjoyed it. Liz, Michael, Peter and James for that quite inspiring discussion. We're now going to hear from the Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, Professor Phyllis Marshall AC, who will officially launch the Low Back Pain Clinical Care Standard.
As Chair of the Australian Commission on Safety and Quality in Healthcare, I would like to thank you all for joining us today. I am very pleased to officially launch the Low Back Pain Clinical Care Standard. The catalyst for developing this standard was data from the Australian Atlases of Healthcare Variation. The atlases identified marked variation in CT imaging of the lumbar spine, use of opioid medicines, and in lumbar spine surgery. Low back pain is a common presentation both in primary care settings and emergency departments. Hence, this new national standard focuses on the early management of patients with low back pain. With the ongoing pressure on healthcare services across Australia, it's important that we provide the most appropriate and effective care. The standard supports evidence-based care and is consistent with international guidelines. I would like to thank all the consumers and clinical experts involved in the development of this national standard, especially members of the Topic Working Group and our panel members today. Finally, thank you for taking the time to join us. I hope that you have enjoyed this webcast and I am pleased to commend this standard to you.
And thank you so much, Professor Phyllis Marshall AC, for that launch. Thank you again, and to all our panellists, and to you, our audience, for joining us today. I do hope this will be the start of some important changes in the care for people with low back pain. You will find a lot more information in the new Low Back Pain Clinical Care Standard. If you go to the Commission's website, there'll be a range of resources for consumers, clinicians, and healthcare services. You'll also find a recording of this webcast, and there'll be more to come in the next few months. So please do tell your colleagues about this webcast and share the resources widely. I have learned a lot. Very glad to be with you. My name's Geraldine Doog, and I'd like to thank you so much for joining us. Goodbye.